Good morning, everybody, and welcome. My name's Lloyd Linford. I am a colleague of John's at Kaiser. I'm the director of best practices development in psychiatry and chemical dependency services for Northern California. I graduated in 1977, and shortly after that I went to work at Kaiser. And it's been very interesting reflecting in the process of writing this book about what was going on in that period. It was really a very, very seminal period, the mid-70s to early 80s in mental health. And we see it as the genesis of an era that we call the Pax Medica. I don't know if you remember from your undergraduate History of Civilizations course, but when the Emperor Augustus took power in about 29 BC, there had been very limited precedent for one-man rule in Rome. He wanted to set up basically the empire. So he established a junta, a group of the most important generals, including some of his rivals. And although there was a very high mortality rate in that group, Augustus survived them all. What happened in the empire was that the civil wars stopped, and it became an era of peace and prosperity. 1977 marked the same thing in mental health. You had had battles, turf battles in psychiatry before that point, one of them being that you had to be, in the United States, you had to be a psychiatrist in order to apply for candidacy in a psychoanalytic institute. And that had tremendous meaning in those days because psychoanalysis, if not the only game in town, was the biggest game in town and in many ways the most interesting. Psychologists and social workers could apply for special membership, but they had to sign a waiver that they would not practice clinical psychoanalysis. So in the three major things happened in this period from the mid-70s through the early 80s. And they all have to do with a bringing back of empiricism into the mental health fields and a consensus about certain basic assumptions, but under the aegis of medicine. In this case, the Emperor Augustus was represented by the American Medical Association and the American Psychiatric Association. One of the things that happened that had precipitated this, it had actually happened a couple of decades before. A very eminent, very empirically oriented psychologist, Hans Eysenck at the University of Chicago, did a lit review of the existing outcome studies of psychotherapy, and he concluded, this is his conclusive statement, that psychotherapy was no more effective than the passage of time. For many years, I was the chief psychologist in the psychiatry clinic at Kaiser in Oakland. And one of my predecessors there was Timothy Leary, who had, before his tie-dye and psychedelic period, had done a study comparing the outcomes of people on a waiting list for psychotherapy in the clinic to people who had finished psychotherapy in the clinic, and there was no significant differences. There were a number of studies coming out which challenged some, which were very bad news, very scary actually for people in practice. And so the academics really got going and started doing a lot of outcome-oriented studies. But again, one of the people who made the most of empirical methods was not a psychologist or a social worker. It was a psychiatrist, Aaron Beck, who started in 1972. Beck knows, by his own admission, knows very little about psychology or psychological theory, but he really knows how to get randomized control studies going, and that includes getting funding for them and getting them published. Beck said that what the field required at this point was indispensable evidence of effectiveness for psychotherapy, and that the way to do that was to basically import the same model that was being used to test some revolutionary psychopharmacological agents that were then in the works, to import that into the study of psychotherapy. So that meant that treatments had to be manualized. You had to be able to say very specifically what the intervention was, and you used a specific research design, controlled randomized control studies, RCTs. The outcome of that was that also what you were doing was that you were targeting treatment, which is, we were no longer doing therapy, we were doing treatment, and you were targeted at specific, not problems, but diagnoses. And the people that you saw were no longer clients, they were patients. Basically, the language became colonized. Certainly those terms had existed prior to the 70s, but a uniformity began to characterize the field. Second huge thing, besides CBT, and that was the advent of the DSM-3. The DSM prior to 1980 was regarded kind of like an exercise in botany. It was a diffuse, depressive neurosis. All these terms not particularly used, and the people who were involved in it, of course, fought like blazes, but it didn't have much impact on the field. After 1980, it had a huge effect, in part because of this emerging consensus. The DSM-3, it's remarkable if you think about it, that prior to 1980, we did not have a diagnosis for attention deficit disorder. We did not have a diagnosis for major depressive disorder. We did not have a diagnosis for PTSD. Many of psychiatry's greatest hits are to be found in DSM-3, which became a bestseller. And it formed a common language for psychiatry, not just within the field, much more uniformity in the field, yes, but it also became the Bible of psychiatry for law in terms of forensic issues in court, for disability management. Keep in mind that depression is the largest source of disability in the United States and at this point in the world. A very conservative estimate is that it's a $44 billion a year industry. And then all the insurance companies making decisions about reimbursement. Third thing, Prozac. Listening to Prozac. Prozac debuted in 1974, really got going later in the decade, and it marked an enormous shift. Keep in mind, this is about the same time I graduated. When I graduated from CSVP, I went to Kaiser for an internship. I went to Kaiser because my primary supervisor was going to be a woman who was a child analyst who had studied at the Hampstead Clinic with Anna Freud. I wanted to be a child analyst, and I could go to Kaiser to learn those skills, but I couldn't get into an institute. Within 5 years, I could. Things had changed dramatically, and they changed partly because of Prozac, because there was an enormous shift within psychiatry, within medical psychology, away from psychoanalysis and toward empirical methods, which included especially antidepressants. In some ways, an interesting and in many ways, as we know, a good thing. It sort of brought the brain back into mainstream mental health. But we never have understood how they work on a scientific basis. The J. Walter Thompson, Eli Lilly's advertising agency for a long time, announced that they work by correcting chemical imbalances, which is kind of an intriguing proposition. But David Burns, who did research on a psychiatrist, clinical and research psychologist, who did research on serotonin for 3 years at Stanford, said he never found an iota of evidence that suggests that serotonin is strongly connected with, in a causative way, with depression. 90% of serotonin is in the gut, not in the brain. And it's sort of like suggesting that if you take something and it alleviates a headache, if you take an aspirin and it alleviates a headache, it's sort of like suggesting that deficit of aspirin causes headaches, and so if you take an aspirin, you've corrected the problem. Nevertheless, by 2005, you had seen a tremendous shift in the field. Antidepressants became the most frequently prescribed drug in the United States. about 1 in 20 men, 5%, 1 woman in 10, about 10%, in the US use antidepressants. And by contrast, about 1 in 20 Americans sees a licensed mental health provider for any type of psychotherapy. So let me talk a little more about some specific impacts within the psychotherapeutic fields of the Pax Medica. The American Psychological Association, several years ago, during the 90s, started a movement to identify evidence-based treatments or evidence-based practices. And the definition of that is, as you see here, at least 2 RCTs showing one method superior to an alternative method. So you're contrasting 2 different methods with a specific cohort of clients, meaning with a specific DRG, a specific diagnostically related group. Totally Pax Medica. RCTs have great virtues when you're comparing 2 relatively simple things, but when you're comparing one person to another, you're not comparing simple things, you're comparing complex things. So the trouble with RCTs in our field is that they can omit many variables and get published. They're also extremely expensive to conduct. You have to have a very large funding source in order to run an RCT. And that while they can you can establish general efficacy on the basis of an RCT, as they have been used, and as you see them in the literature, the net effect of this is that they overestimate the importance of psychotherapeutic technique. These are some assumptions that I think I've clarified or embedded in the Pax Medica. Perhaps not so much that patients are seen as embodiments of psychiatric disorders, but that's an artifact of the RCT, that you define these people as people with a diagnosis, and what you're doing in the treatment is removing the diagnosis. So practically, virtually all forms of ESTs are CBT. And if you just notice the brochures that you get in the mail, they are specific techniques for a specific diagnosis. SSRIs are ubiquitous, and diagnosis is used by third-party payers and HMOs, like the one I work for, to determine who gets treatment and what the nature of the treatment is going to be, and what defines outcome, and who gets disability and who doesn't.